So, hi, welcome to the lecture 2.5, which is going to be on the Mulligan approach. So, today's topic is going to be a recap of contents covered in the first two lectures. Again, my name is Chris, and I'm your physiotherapy student. So, let's get things started. What is the Mulligan approach? So the Mulligan approach is a manual therapy approach developed by the physiotherapist Brian Mulligan, a student of Caldenborn. And so his thinking is like with his first success of the mobilization with movement in the patient with swollen finger and a painful flexion and extension limitation, and so a lateral glide is painless and sustain the pain-free lateral glide together with flexion extension performed actively, and in just one session there's immediate effect as well as a long-lasting effect, which reflects all the principles in pill, pain-free for both the glide itself as well as the mobilization together with the sustained glide, the movement together with the sustained glide, i.e. the mobilization with movement, as well as the instant effect, which is pain-free effect, which is not seen in other manual therapy approaches, as well as lastly the long-lasting. So the pain-free effect, not only should it be immediate but also will have a lasting effect, and possibly with one or two sessions that the patient is completely discharged. And so that's for we've covered briefly as to how the history of it, the first success of the mobilization with movement, as well as the first principle of the mobilization with movement with the acronym PIL. And there's also the other acronym. The other acronym is the CROCS, CROCKS. So the first C is going to be contraindications. You need to check the contraindications, like hypermobility, very high severity, irritability, or effusion, joint effusion is going to be contraindications, and there are a lot of precautions as well. Repetitions is important. Mulligan generally prescribes 3 sets of 10 repetitions. If the effect is going to be very good in the first set, so you may not need to perform the other set. And so, but the repetitions can also be dictated, not only by the general guidelines, but also by the patient-specific parameters like the irritability and severity level. If it's high irritability and high severity, you may want to be more cautious with the first session in terms of the repetitions. So we've covered the C and the R, and then the O. O is for overpressure. So overpressure is important in patients with the chief complaint of being range of motion limitation. It could be stiffness causing the limitation in range of motion, or pain limiting the range of motion. So in these cases, range of motion is going to be the endpoint, and you want overpressure in these, especially in these type of clients. And so a failure of applying overpressure in these patients may restrict the efficacy of the mobilization with movement technique. And CRO, and then the other C is going to be communication and cooperation. So these are very important, so you need to ask for consent and ask for cooperation, since the active movement is performed actively by the patient, and the overpressure may also be a client directed overpressure, and so you need to communicate and have the patient cooperate with the therapist. Not only is the patient going to be having the feedback, yes, also you need to ask for pain as the response, it needs to be completely pain-free during the technique, so you need to consistently ask for a response from the patient as for the pain. And so it's a two-way, so not only the therapist needs to give different feedback for the patient as to what kind of instructions or ask for consent, but also the patient needs to give feedback to the therapist in terms of the pain response as and other stuff. Okay, so that's the C for communication and cooperation. And then the knowledge part. The knowledge part is the biomechanics, the kinematics, the anatomy. These are all things that the therapist should be equipped with. And as for the last one would be the S. So in the first of the last, the S will generally be sustained, but there are also other types of definitions of the last S. So S for sustain. So sustain is going to be meaning that the glide, the mobilization needs to be sustained throughout the entire range of motion, not only with the let's say you're trying to improve elbow flexion, not only during the range of elbow flexion, but also the return towards the extension direction. So sustain is the last S, and so these are the pill and the crux are going to be the principles of the mobilization with movement, which is very important. And then next we'll recap the mobilization as well as the movement components. We'll start with the movement component element of the mobilization with movement, which is the letter M, and so movement. So a client specific impairment measure is going to be the key term CSIM. So what is the patient's chief complaint? Is it elbow flexion or knee flexion? So it will help determine your joint that you're going to try to investigate, and then which kind of bones it is, and so yeah. And then also you need to understand as to what is going to be the endpoint. If you're trying to target pain, is it your target stiffness, or you're targeting the force production? These are all things that you can possibly target. There are also other things as well, like you need to consider the comparable sign. You need to trigger the patient's comparable sign, for example pain. So you need to move towards the pain and make it pain free. And also the point as to why CSIM is important is because it can connect the treatment effect to the patient's problem and make the treatment more meaningful to the patient. Okay, so other things that you need to consider is that if you're going to break down the CSIM or not. So let's say it's too irritable to perform deep squats in the functional position. Can you consider like a non-weight bearing position? And for the mobilization element of it, so the two parameters or the reference points is going to be one, the input parameters, and two, as to what is the effect of the parameters specifically to the CSIM of the patient. And so you need to possibly try out different accessory motions with the patient. Lateral glide is the most common one, but you can also consider like the medial glide, the anterior posterior glides, or traction rotation forces. And you need to consider the direction of it, not only the growth that we've talked about, so the 6 grosses, and as well as the subtle ones. The subtle ones is that can you consider a little bit different, like a 10 degrees difference, not a pure lateral glide, possibly 10 degrees posterior directed as well. And so gross and subtle are things that you need to concern about the direction, as well as for the force, the amount of force that you need. Generally, half of your force, maximal force production, or 2/3 of it would be recommended, but you can try out as to with the least amount of force required to achieve the desired effect may be a better one to commence with as a starting point. And next, as to things about the second lecture, the mechanisms and effects of mobilization with movement. We've covered the key mechanism domains, the peripheral, the central, and the output response as domains. And for the peripheral mechanism, we've gone through the positional fault hypothesis that maybe let restoration of the positional fault, the faulty normal kinematics. Yes, you can improve the joint kinematics and make it pain-free if there's any deviation of the bony alignment. And so there's also the other peripheral mechanism, which is the altered receptive input. So there are many mechanoreceptors in different joints and muscles, and possibly with the mobilization with movement technique, we can reduce the nociceptive signals or increase the non-nociceptive signals and make it less painful. And we have also gone through the central mechanisms like the mobilization with movement can possibly trigger the endogenous inhibitory mechanisms that decrease the pain with the descending endogenous opioid system pathway. And also we can another hypothesis or theory is that it can have the placebo effect, that since especially for the chronic pain patients, that pain has been really a problem in their daily lives, and with this mobilization movement technique, suddenly the pain is everything gone. Okay, so pain free completely. Also, it makes the patient feel like that the problem has been identified and a solution has been identified and provided to the patient. So there's the implicit reassurance given to the patient. And lastly, we got the extinction learning. So it's some concepts related to the classical conditioning / associative learning type of things. So neurons that fire together, wire together. So a patient may have the pain, which is the unconditioned stimulus, linked together with the neutral stimulus of the movement. So over time, after conditioning that the movement, originally the neutral stimulus becomes the conditioned stimulus, and so even in the absence of the nociception, it will trigger a pain-like feeling. And so mobilization with movement, it will have the pain-free movement together with the mobilization, and so it can possibly weaken the association between the pain response and the as well as and the movement component. And so this is called the extinction learning in terms of the classical conditioning theory. Okay, so the last part is going to be the response mechanisms. So motor relearning, mechanoreceptors, and the motor systems, that the mobilization with movement creates a discrepancy between the expected and the actual sensory feedback, and so the body would try to have changes in motor activation that intended to correct that discrepancy. Okay, so that's all for the recap. I hope that you've get back to all the key points in these first 2 lectures. Thank you. And again, my name's Chris and I'm a physiotherapy student, so I'm checking out.